Okay, good morning, everybody. Happy Tuesday. It's quite a rainy Tuesday here in Baltimore. I don't know how the weather is out in California, John, but it's kind of been gloomy. We've been having quite a bit of unusual weather for this time of year, but great week, orientation week for us, new interns. You probably have new interns in your program as well, and congratulations to all the incoming interns in all the fabulous programs across the US. Um, and I like to introduce first, I'll have John unmute and introduce himself, and then Beza will unmute and introduce herself as well. And she is one of our residents here at Sinai, and she'll be presenting a case today. So I'll start with John. How are you doing, John?
Okay, I'm doing very well. So for those who haven't talked with me before, I'm a general internal medicine doc and one of the Clinical Problem Solvers Academy members. And the weather in where it's starting to get a little bit excessively hot here, not too bad, still okay in the mornings and the evening. And it's just such an exciting time of year with the new interns starting their orientations and that natural just mix of excitement with anxiety that everyone experiences when you go through that transition. It's one of my favorite times of year to be on service, actually. I think it's a lot of fun and big pleasure, privilege. I'll turn the mic over to Beza.
Hi, everyone. I'm Beza. I'm one of the PGY1s at Sinai Hospital of Baltimore. I will be presenting a case today.
Awesome. And then we have our Academy members who help us with teaching points and scribing. Sime, how are you today?
Hello, very excited for Beza's case and discussion by Dr. Ravi John. And contrary to weather in Baltimore, here we have intense heat and actually a heat wave going on. And other than that, very excited for the session.
Awesome. And yeah, I don't mind a little heat coming this way. It's been kind of gloomy for June. Eugene, how are you?
Hi, Dr. Ravi. I'm doing well. Yeah, so I'm Eugene. I'll be doing teaching points, and I'm excited for the new case.
Awesome. Thank you for your help. And let's get started with the first aliquot. Over to you, Beza.
Okay, for the first aliquot, I have a case of a 23-year-old male who presented with complaints of cough and shortness of breath of 1 week duration with new onset pleuritic chest pain.
You want to start with that, John?
Yeah, right on. So it sounds like, correct me wrong, like 1 week of cough, shortness of breath, and pleuritic chest pain.
Yes.
So think about you have pain that's worse when you take a deep breath. It is trying to, I'm using that to anatomically localize a little bit, that just keeping it broad, something that's irritating either the diaphragm or the pleura on the mediastinal side. And there's a lot of things that could do. It could be something from pathology below the diaphragm. It can be a pneumonia. Probably the reflex diagnosis that can't miss one that we can't think of is usually pulmonary embolism. So we kind of zoom into that when we do our history and physical and try to exclude our can't miss diagnoses early on, like a pneumonia, pulmonary embolism, anything irritating the pericardium that's neighboring the pleura. So thinking about the pleura and its anatomical neighbors and localizing that with the acute time course, the fact that it's been going on for 1 week is another part of the equation that will help us frame our differential. So with thinking about the base rate of disease together with what things are dangerous for the patient, what's common, cough, pleuritic chest pain, 1 week time course, an infection like a pneumonia would certainly be a common thing to explore. So yeah, I think that's how I would focus my continued history and exam, trying to add weight or take it away from some of those hypotheses. Ravi, what else you got?
Yeah, I think that's a fantastic start. I like that. There is a very nice CPS scheme. I implore everybody to look at it. It was one of the early ones. We have the chest pain with the 4+2+2, but then here Bez has mentioned a buzzword, which is pleuritic chest pain. And then the schema does a very nice job, and I think it helps you to make progress with this certain condition if a patient complains of this, which is what John had just mentioned. Like this is pain, but it's due to taking a deep inspiratory effort. And what are you doing at that time is stretching the lungs. Now, cough here maybe won't allow you to make progress here. It may be a cohabitant with the pleuritic chest pain. As you take a deep breath, the nerves may be, or the pleural nerves may be irritated, the bronchial nerves may be irritated, and a cough may happen. But the pleuritic chest pain is concerning. And like Jonna mentioned, everything that the lungs are touching is fair game for a pathology. So it could be anywhere. If you see the lung hits the chest wall and the mediastinum, and then also the abdomen. So any of those areas could harbor disease, and the ones that you really want to be careful about are the real dangerous ones that John had mentioned. And I think we'll start with that, really exploring the landscape of pleuritic chest pain and trying to see what could get us rapidly to the diagnosis. The other thing is a young person, and we always kind of talk about a young person. They really shouldn't be coming in. If they are coming in with some complaint, it's got to be something ominous. And so we do sort of use this introductory sort of a moniker, this bad genes, bad background, bad habits, and so on. Well, I'm forgetting some of those aspects, but could this be something? What that is essentially means, could this be something intrinsic to them, maybe bordering on autoimmune, genetic? Could it be something bad background? Could it be something external, like maybe toxins and so on? So those are a few things I would think about. It's been 1 week, and questions I would kind of ask is this getting worse? Why did they come in now rather than like 7 days ago? So something must have happened, or it just didn't resolve, or maybe it got worse. So those are a few questions I would ask in the HPI. Back to you, Beza.
That's actually a great question. I'll elaborate a little bit more on that. So for history of present illness, he initially presented to an urgent care 6 days back with a 1-day complaint of cough and shortness of breath. The cough was productive of yellowish sputum with occasional blood-tinged sputum. He had associated headache, fever, chills, myalgia, sore throat, and rhinorrhea. At the urgent care, he was given doxycycline for a diagnosis of community-acquired pneumonia and benzonatate for symptom management. Despite taking the doxycycline, his symptoms persisted, and he developed this right-sided chest pain, which was exacerbated by coughing and deep breaths. This new symptoms and the lack of the resolution of his previous symptoms prompted him to visit the ED. For review of systems, he denies any weight loss, no night sweats, no anorexia, no orthopnea, PND or arthralgia, no hematuria, no rash, no hearing loss, no vision changes, no recent immobilization, no history of trauma, surgery, or known hypercoagulable state, and no sick contacts.
Very extensive HPI there. What do you think, John? What really helps you shed light on this problem?
Yeah, so a couple pieces of data that we'll use is a lack of significant change in the trajectory of the course with doxycycline. And we have this cluster of symptoms. I heard headache, fever, chills. I think I heard sore throat and rhinorrhea, myalgias. So it's this collection of symptoms. We sometimes think of it as, it strikes me as thinking possibility of an underlying viral syndrome. You'll see it with tick-borne and some other systemic symptoms too. And so if it didn't improve with doxycycline, you think like which could has some coverage for strep and other common organisms that could cause a community-acquired pneumonia. But I'd say it doesn't completely take away the possibility of community-acquired pneumonia as a hypothesis. Could be just not providing the sufficient coverage. Or do we have an evolving process, perhaps something that started with a viral or other infection and has evolved into a more systemic syndrome? So still a little bit early for me to put down a specific differential diagnosis or leading theory yet, but I'm getting early on a viral flavor to this disease process that's now become progressive to the point where they are presenting to the emergency department. Yeah, what do you layer on?
Absolutely. I think the momentum is sort of building here with the HPI towards some sort of complex. Could it be, infectious, and a subheading would be viral. These non-specific sort of constitutional symptoms, John, you had mentioned, yeah, they're like not really allowing us to make progress, say, on a certain condition like pulmonary embolism. Pulmonary embolism can, I mean, a 23-year-old, it's sort of odd. You then have to wander into the autoimmune category, prothrombotic complexes, but it's kind of early to really go there. I think we have enough of a pretest probability for viral pathology, maybe. And especially this time of year, we have a number of different viruses making rounds. Even bacterial complexes are still around, and patients are still coming in with pneumococcal pneumonia and so on. Doxycycline is interesting. I don't use it as monotherapy. We do have this sometimes with these cases where somebody presents to an urgent care clinic or outpatient clinic and gets empirically treated, but there's no improvement. You would imagine there would be some, or anticipate some improvement with the antibiotic. But could it be that the doxy is not sufficient for coverage? So maybe I would have done a fluoroquinolone, like levofloxacin, to have a more broader coverage. This patient is coming from the community. Doxy, usually I would use for atypical coverage for pneumonia, but monotherapy by itself, probably not. What could be a better antibiotic if you're trying to cover bacterial, maybe augmentin may be useful in this case, but we don't have enough data. You know, we're moving towards maybe a bacterial viral pathology. Labs will be interesting at this point to make some progress, and imaging, I think, is key if this patient's having continued cough along with this constitutional complexes. You know, the review system's great. There's no weight loss, so does it entirely take off malignancy? It doesn't, but it's always interesting. You get this key word or key feature right then and there, because there's also hemoptysis, right? Hemoptysis, we worry about, is it significant? Does it meet the criteria for significant or massive hemoptysis? And when you are in the domain of hemoptysis, you have to worry about certain things, maybe endobronchial lesions. Is it, first of all, though, let me retract that, actually walk back. Is it actually coming from the bronchial cheek? Because upper GI bleed, epistaxis, there are some pseudo hemoptysis complexes that may kind of send you down a deep rabbit hole. So before even exploring hemoptysis, are you truly really dealing with real hemoptysis? Second thing is it an anatomical bronchial, upper bronchial tree, lower bronchial tree complex as well? But commonly with pneumonia, you will get some little bit of hemoptysis. I wouldn't even go further or go deep into good pastures and so on. Like last week, we dealt with IgA vasculitis. So if there's associated kidney disorder, you would start thinking about good pastures, one of the GN kind of categories there. But at this point, I think we're still it's early on in this case, and I think we may be dealing with bacterial viral. Imaging will be key, and also quantitate the amount of hemoptysis. Is this something that we need to really prioritize at this point, or is it something that's just a bystander in this case? Any other thoughts, John, before we move back to Beza?
Yeah, I think trying to be authentic with how I would be taking care of this patient, I would still be rooted in the bread and butter common causes of this kind of presentation before, you know, launching into the more exotic things. So could there still be, you know, community-acquired pneumonia that was incompletely treated or has developed a complication like a pleural effusion that's empyema or pulmonary abscess, or complications of a viral infection like inflammation of the pleura, or pericarditis or something. So that's still where I'm rooted. But I think, you know, a good, you know, getting an exam and getting an initial evaluation of the airspace with a chest X-ray will help us make some progress here. So yeah, let's take it away from there.
Before I go to the third part, just to describe the hemoptysis a little bit, he did say that the sputum was blood tinged, so it was minimal amount of blood in the sputum. So for the third part, his prior medical history is significant for ADHD, for which he's no longer on any medications. He does have a history of asthma, for which he uses as needed inhalers, and history of allergic rhinitis, for which he has fluticasone nasal spray. For more recent past medical histories, he endorsed a few months of recent epistaxis from the bilateral nostrils, which was self-resolving and with minimal blood loss. And he has had multiple ED visits in the last couple of months for ischemic priapism. For social history, he lives with his parents in a suburban area. He is not employed, so no occupational exposures. He has no recent travel, no history of incarceration, no exposure to pets or soil. His family history is positive for asthma in his sibling and diabetes in his maternal grandmother. Health-related behaviors, he uses marijuana regularly. His last use was on the day of his first symptom onset. He denies any history of smoking cigarettes, no other drug use, and no alcohol use. For physical examination, his vital signs were pertinent for fever, maximum of 39 degrees Celsius, and pulse rate of 128. Other vitals were within normal range. For HENT, he did have dried blood noted from both nostrils with marked nasal congestion, and chest examination revealed diminished air entry in the right upper chest. For labs, his CBC showed mild leukocytosis of 12.75, hemoglobin was 12.6 with an MCV of 81, and platelet count was 634. His CMP was pertinent for a sodium of 132 and albumin of 2.7. He had elevated ESR of 75, CRP was 360, procalcitonin of 0.49, and a D-dimer of 2.6. His RVAP was negative, UTOX is positive for cannabinoids, UA showed trace proteins, chest x-ray showed right upper lobe consolidations, and a CT-PE that was done showed no PE, but a multilobar pneumonia.
Oh, very interesting. Great presentation so far, Bez. I'm very proud of you. And now, what really strikes me here, John, is this recurrent visits to the ED for this ischemic. Is that right, Beza? Ischemic priapism. So,
Correct.
the only time it's interesting, like type 1 thinking, knee-jerk sort of thinking, quick, I guess, rushing to judgment, sickle cell comes to mind. But there's more behind that causing a ischemic priapism. So in this condition, you start worrying about, and also if you bring in this epistaxis, I'm wondering if we're dealing with a vascular or hematological complex here. So what kind of conditions? I named one, which is sickle cell anemia. Other one would be thalassemia. Are we wandering into the domain of leukemias? Some of the leukemias can be lymphomas. They're sort of like on a spectrum. And then you also worry about any sort of thrombotic conditions. Then you have to consider what can cause bleeding and also cause congestion within the penis and causing this ischemic priapism. So just imagine sort of a jam pack in the flow, causing ischemia, excruciating pain. That will bring you to the emergency room. And I can't even imagine this. And having several of these visits, you then wonder if this was worked up, was there an answer for this, or the patient just deals with it and comes to the emergency room and gets treated for it. And yeah, other than these complexes, I don't have any other cause or any other thoughts about what could be causing this. For the epistaxis, definitely, I mean, the CBC, we have platelets of 634, so we do have to wonder, is the epistaxis due to a platelet disorder? Is it due to a coagulation disorder? Is it due to a anatomical disorder within the nose itself? Could there be vascular malformations for severe epistaxis, which could go posteriorly into the stomach and be a pseudo cause of upper GI bleed or hemoptysis? A posterior nasal bleed would possibly be a fault. Anterior nasal bleed, not as dangerous in this case, but it won't be as rigorous a bleed as a posterior nasal bleed. That will be anteriorly. And in your exam, you mentioned there's dry blood in bilateral nostrils. You also have to wonder about trauma, but I'm trying to link that to this ischemic priapism that this patient's having. Any thoughts come up, John? Kind of interesting conundrum at this point.
Yeah, it's interesting. So there's like some pieces of data I was expecting and some that they're not. like the airspace opacities, elevation in white blood cell count, fever, tachycardia, signs of inflammation. That all was kind of what I was expecting. But this, especially the recurrent priapism, the epistaxis, kind of layering on to the case. And we've learned that there's this a background of basically atopic conditions, asthma, allergic rhinitis in the background. The may or may probably at least relevant in some way in terms of their risk of pulmonary disease. So I think like with priapism, I'm still struggling a little bit with how to layer that in. There's some kind of risk of prothrombotic condition at play here, layering in with a fingerprint in the pulmonary system. I'm just like I see pretty rarely outside of things like sickle cell or sometimes like cocaine, cocaine use, sometimes adverse effects of some other medications, but it doesn't look like the patient's on anything that would explain that. It does think about so possible vascular territory here. And really like a reflex respiratory symptoms, not getting better, and at least initially with doxycycline. But if you change the steroid bit and it's not getting better with appropriate coverage, then thinking about the autoimmune world and asthma, atopic conditions, a reflex thought of EGPA, which will certainly look for other fingerprint for that. Things look for eosinophilia, to dive into family history a little bit more. And this, epistaxis and the nasal involvement, it's more of a hallmark of GPA than EGPA, but it's still possible. That's a cause there. In reality, this patient would still be what would be doing them for this first pass in the hospital? They're febrile, they're tachycardic, they're sick. They would be getting blood cultures or broad spectrum antibiotics in the first pass whilst watching for a fingerprint declare itself somewhere else. But the epistaxis in the setting of normal platelets and recurrent priapism is catching my attention. So the platelet count is normal. So I think you highlighted could be a problem with the function of platelets or the coagulation cascade. I didn't see a PTINR yet, so I would check on those. Or anatomical problem, the asthmas or some bad polyps that are predisposing the person to bleeding, and maybe it's unrelated. So a challenging case. Don't have a confident diagnosis at this point yet. Well, let's keep exploring.
To answer the few questions that were raised, for recurrent ischemic priapism, he was not worked up for sickle cell at the time of presentation to the ED for this new complaints. No eosinophilia on his differentials, and no PTINR abnormalities. For the fourth part, so this is just his hospital course. On day 1 in the ED, cultures were drawn, blood culture, sputum culture, Legionella and Strep pneuma antigen were sent, and he was given ceftriaxone and azithromycin. On day 2, pulmonology was consulted because of this failure to treatment as an outpatient, and antibiotics were changed to cefepime, metronidazole, and azithromycin. On day 3, ID was consulted as the patient had no resolution of symptoms. He was still febrile, tachycardic, had persistent cough and chest pain. So all other antibiotics were discontinued at the time, and the patient was started on meropenem with cultures pending. After changing to meropenem, all cultures came back negative, and the patient was still with symptoms. So a repeat CT was pursued, and it showed unchanged multilobar pneumonia, but this time it also showed a necrotizing pneumonia/abscess formation in the right upper lobe. A BAL was performed with no purulence appreciated during the procedure. Pathology results from that showed no evidence of malignancy or a granulomatous inflammation, and a few other workups were pending at the time.
This is really getting interesting. I thought, John, we were kind of in the domain we were thinking about, okay, maybe this is unproven or undiagnosed, but sickle cell wouldn't at 23 years of age. So that sort of condition, I would move it to the side or put it on the back burner. The autoimmune phenomena, this fever, we're trying to consider this fever, and I think the team here was thinking there's a significant burden of proof for infection. And you see multiple different antibiotic combinations eventually landing with meropenem. Meropenem is extremely broad. I mean, majority of times I'll use it for ESBL infections, but it has actually gram-negative, gram-positive, pseudomonal. It's the only carbapenem, or no, it's one of the carbapenems that covers Pseudomonas. Ertapenem doesn't cover Pseudomonas. So you do cover multi-drug resistant organisms and also anaerobes. The only thing you won't cover is MRSA in this case. So an abscess is found, and the only time we treat anaerobic infections in the lung is if you have empyema or abscess, or if you have a patient with terrible teeth that heightens the necessity for coverage with anaerobic coverage in this case. So this fever here with repeated antibiotic changes and no resolution, the I-MAID mnemonic is very useful, right? I love teaching this to my medical students because occasionally they'll see in the hospital patients with fevers that are not due to infection. The white count you mentioned was high, 12.7. So fever and white count does point towards infection, but then you have to start thinking about other complexes that could be of a non-infectious etiology. So vasculitis was sort of deployed early as a possible cause. EGPA can involve the upper respiratory tract, lower respiratory tract. You don't always possibly have eosinophils in this case. And then I'm trying to think about vasculitis with this ischemic priapism, definitely with the vessels and the abnormality with vessels that you can have. Earlier on, I was very excited. Maybe we have CML, AML, one of those hyperviscosity syndromes, and you can end up having leukostasis. Although the white count here isn't within that range to cause leukostasis or sort of infiltration, no thrombocytopenia, no pancytopenia to suggest low platelets and bleeding here. So I'm wondering, could there be two simultaneous processes, the primary process causing immunodeficiency here, causing this infection, or is this all the same thing that we're dealing with? So wondering at this point, and these upper lobe consolidations, can this be reactive TB? I'm trying to think about TB. Epistaxis can happen. The priapism, I have no idea about if it's associated with this, but something to think about. We haven't done the usual workup, autoimmune, I mean, the immunodeficiency workup. HIV would be one of the first order of business here to do. Any ideas at this point, John?
Yeah, a lot of the same thoughts you're sharing. I think like the more time that goes by with the person getting broad coverage with antibiotics, I didn't quite catch all of the different agents along the way before meropenem added, but making sure we've covered broadly for atypicals and MRSA. But the likelihood of infection does get lower the more time that goes by with the antimicrobials that are being guided by infectious diseases consultant in the hospital. So we're talking about. I loved the thought about HIV. That was one of the first things I was thinking in my mind too, is defining the risk, the immune status of the host. If they're immunocompromised, do we need to think about even more broad, unusual organisms that we wouldn't usually cover in our first pass? Just thinking critically about what are we not covering? Do we have to be worried about not just bacterial, but things like fungal infection as well? And like I presume the person was screened for sickle cell, but it was kind of the reflex that could be a potentially unifying thing with causing ischemia, causing nosebleeds, causing priapism, acute chest syndrome could be a way to tie it all together. But presumably they usually would be screened earlier in life, so that would be very unusual to catch the sickle cell such later in life. So I think I saw it looks like there was a BAL. Just I looked away for a moment. Did the patient already have a bronchoscopy? That be potentially one of the steps next to try to either get tissue to help us. But some things I would do screening for HIV, consider testing, fungal cultures, testing for endemic fungal infections, and sending that like some of the first pass with the ANCA serologies to explore GPA, eGPA line of thinking.
Back to you, Beza.
So HIV, hepatitis, and TB were all sent. They all came back negative. Beta-D-glucan and galactomannan were also done, and they were negative. But on day 8, the workups that were pending, the CANCA and the PR3 results came back positive, and he was diagnosed with granulomatosis with polyangiitis. Meropenem was discontinued as all his culture results came back negative, including the ones from the BAL. And rheumatology and ENT were consulted. No significant ENT findings were appreciated, and he was discharged with an outpatient follow-up with ENT and rheumatology. I'm sorry, I'm not sure if I mentioned that he was started on steroids, and his symptoms actually improved significantly. His tachycardia improved, his fever came down, and he was feeling significantly better. So he was discharged. After discharge, he was started on rituximab at an outside hospital. There, they did work him up for sickle cell, and he did not have sickle cell trait or disease. So this is actually one of the unique things about this case. I did only see one case report of a patient with a vasculitis having ischemic priapism. It would be reasonable for it to have a correlation given that it's a small vessel vasculitis, but that's why this case is also very interesting.
Wow. Yeah, there was, but this kind of reminds me is of a case many years ago that Reza and Ravi solved. It was a case of priapism. I'm trying to remember who presented. It was one of our longstanding members presented that case, and kind of has that sort of flavor, I would say. But yeah, it was interesting. Along this case, or trying to think about this case, these vessels were the only explanation. And I think of vasculitis, I've not seen or heard of a case where vasculitis caused ischemic priapism. Although it can, if you think physiologically, you can cause that if you think about it. But what's troubling is this patient has been coming repeatedly for this, and it wasn't worked up. And of course, sickle cell disease, we all know that. That's what we're taught primarily. But then you have to look behind the curtain to see what else could be causing this. And it was only until he had other manifestations of this of GPA that this was then diagnosed. But very interesting. And the response to steroids is amazing. I mean, that's definitely turned his life around, and he's markedly improved and now functional and interesting. Yeah, Franco helped you with this case, so I was gonna say he definitely would have an autoimmune flavor, but this is key here with the fevers. Like we had mentioned, start thinking beyond just infection. And I did present a case to Ravi before of a young person actually that presented to a neighboring hospital with he came from South America, had repeated like fevers, and he had infiltrates repeatedly treated, and TB was thought, but it was GPA. So GPA can manifest in many different ways. Always keep that at the front of your mind. And I love that, John, that you mentioned. Just get the serologies, get the autoimmune testing and HIV, and then see if those get you to the diagnosis. If not, then you go move on to other further testing. Any reflections, John?
Yeah, really great case. I think I love how it starts off with a bread and butter acute respiratory symptoms, talking about, and where my thought train was going with, viral and bacterial infections, and what are the common complications that could happen to those that might cause somebody to, incompletely respond to treatment and not get better with time, leading into us finding that they were very inflamed and had this quite a turn with the episodes of priapism and epistaxis. And when getting our basic labs, they're seeing like elevated platelet count, starting to have some thoughts like, is this reactive from this inflammation? Is there some kind of hypercoagulable state in the background, a myeloproliferative neoplasm, or some leukemia before we see the differential and the coags that pushes the weight away from the bone marrow in a hematologic process, or thinking more systemically. And then I think that then just the more time that goes by with the antimicrobial coverage, that you think beyond infections. You always prioritize infections first, because treatments for cancer, autoimmune, other causes of inflammation will get worse if you profoundly immunosuppress your patient early on. So ruling out and treating empirically for infections is definitely the appropriate thing to do when somebody's coming in sick and inflamed like this. So it's good thinking about, thinking about the antibiotic failure differential diagnosis. And we talked about how, are we not covering, is it something we're not covering, like a MRSA or a fungal organism? Is this patient immunocompromised to make us think about these atypical things? Is it a privileged anatomical space, like a pulmonary abscess or an empyema? Is the medication not reaching its target tissue? Is it dosed correctly? Is there a med-med interaction such that you're not getting your therapeutic effect? Or is it not an infection, which turned out to be, in this case, with the clues being some of these things that just didn't quite belong with your run-of-the-mill pulmonary infectious syndrome, epistaxis and priapism, clued us in to think more broadly early on. So yeah, really great case, starting with bread and butter and some interesting twists and turns along the way, and really, well-told story.
Thank you, Beza. Great presentation. Please come back, bring more cases, educate us on these very rare presentations of these diseases. And we'll switch it over to Sime for teaching points.
Yeah, thank you, Dr. Ravi.
Oh, sorry. Sorry, Eugene.
That's all right. Yeah, so this was a young male who presented with initially bread and butter symptoms of lower respiratory tract, and then also some upper respiratory tract symptoms, kind of skewing us towards a pneumonia at first. And so this patient received some antibiotics, but then was not resolving. But we also got to know that there was a past history of recurrent ischemic priapism, and also has some epistaxis. And it was quite interesting that tying that together and then doing a CANCA, we got to know that it was a GPA. And the pointers to the GPA from the beginning was the fact that this patient had recurrent priapism, which initially we were thinking it could be sickle cell disease, but was never screened for sickle cell disease. Epistaxis is one thing that also pointed us to multiple pathologies, but vasculitis came up. And eventually this patient had a form of small vessel vasculitis. So that would be the teaching points.
Great teaching points, Eugene. Very concise and to the point. So I love that. A few points to take home and really dwell on that. So thank you for putting those all together. Thank you, John, for co-discussing, and Beza, once again, absolutely phenomenal case. Please come back. Lots and lots of luck in your PGY2 as you start next week. And take care, everybody. Happy Tuesday. Bye.